Welcome back. For this lecture, we're going to cover the basic pathophysiology and assessment for airway and respiratory patients. When we talk about pathophysiology, we're talking about a disease state that's varying from the normal physiologic process. Pathophysiology is a term that we use quite frequently in medicine, and we use it to kind of describe any disease state or underlying variance from normal, if you will. So with this, it becomes important for us to have a significant understanding of the normal physiology of so that we can talk about the pathophysiology or ways that in a disease state, respiration varies for the patients we're going to see. Remember back from our anatomy and physiology review that there are several factors that influence how the respiratory system works. This includes chemoreceptors that monitor levels of oxygen, carbon dioxide, hydrogen ions, and the pH of the cerebral spinal fluid. Each of those help drive respiratory rate and tidal volume in our patients. And they provide feedback to the respiratory centers of the brain to make those adjustments as needed. For the respiratory system to work normally, it requires a coordination between both the circulatory system, the heart and vessels, as well as the pulmonary system, the lungs. The blood needs to meet the lungs, the new air that's coming in through the lungs, to be able to be oxygenated and exchange carbon dioxide at the lung tissue, as well as the circulatory system needs to be able to move that oxygenated blood to the cells where it's needed. When we don't have adequate perfusion, or the circulatory system is not appropriately delivering blood to the lungs or delivering blood to the cells, we have something called a ventilation perfusion mismatch. And this is often abbreviated as VQ. We discuss it in the terms of VQ mismatch, and we look for the VQ perfusion ratio to ensure that adequate ventilation and adequate circulation are working together to ensure gas exchange. Air and blood flow must be matched in the lungs, and then blood flow must make that to the tissues. And we have several pathophysiologies that are in place, or that we discuss in EMS, that relate to this ventilation perfusion mismatch. The ventilation perfusion mismatch can occur in a couple of different ways. There could be a situation where gas exchange doesn't take place in the lungs. So for example, if we look at something like a large pulmonary emboli, or where a clot is in the lungs preventing blood flow from reaching the alveolar tissue, then despite the effort of the lungs and the pulmonary system to oxygenate blood, no blood flow is getting to that area of the lungs, and that blood thus doesn't engage in that gas exchange of oxygen and carbon dioxide. There also that can result in a lack of oxygen in the bloodstream, and it can cause CO2 to be recirculated within the bloodstream, and this can lead to severe hypoxia or hypoxemia. This is a term we haven't looked at a whole lot so far, so let's break that down a little bit. Calling back from our medical terminology discussion, hypo meaning low, hypoxemia, the suffix ia meaning state of, and oxy being oxygen, a low state of oxygen in the blood is what we're referring to with hypoxia or hypoxemia. Other factors that can affect pulmonary ventilation, we can have things like intrinsic factors. And when we see this word intrinsic, we're talking about things that occur inside the body. So there are various intrinsic factors that occur that can either prevent perfusion, circulatory system, the blood flow movement, or ventilation, or respiration, gas exchange. These can include things like infections, allergic reactions, or unresponsiveness. And if we drill down a little bit deeper into each of those, infections can cause inflammation or secretions within the lungs, preventing the air from actually getting to the alveoli to exchange gases. Allergic reactions can constrict the upper portion of the airway, again, restricting airflow, making it to the alveoli for gas exchange. And the same with the tongue obstruction in a patient who is unresponsive. And a little later in the lectures, we'll talk about some of the airway obstructions and how to manage those, but the most common airway obstruction is indeed the tongue. And then you can have extrinsic factors, and these are factors that occur from outside of the body. Things like trauma. Okay? foreign body airway obstructions. Each of those can also prevent an appropriate ratio of ventilation and perfusion, remembering that we need both of those to work in concert together. There are also other factors that affect respiration, including external factors, and these are things like atmospheric pressure or the partial pressure of oxygen. You'll discuss in environmental emergencies that as altitude changes, you can also see a change in the partial pressure of oxygen. And this means that the oxygen concentration is lower. If you ever look at folks that are hiking up really tall mountains or on Everest, a lot of times they take oxygen with them, or they go through series of stops along the way for an extended period of time to acclimatize to the lower partial pressure of oxygen in that atmosphere. And then internal factors like pneumonia, we discussed earlier, pulmonary edema, this is fluid in the lungs, and things like COPD, emphysema, all can impact the ventilation and respiration side of that ventilation and perfusion ratio we're looking at. We can also have issues that create circulatory compromise. I mentioned this a little bit with the pulmonary emboli. Trauma emergencies can also obstruct blood flow to individual cells. So we may be looking at a patient who is hypovolemic or low blood volume, in which case the blood may be oxygenated at the lungs, but it may not be able to make it to the appropriate tissues because of low blood volume and low blood pressure. We can also have other obstructive causes, so like pneumothoraces, pneumothorax, and that's where air builds up in the pleural space and causes the lung to collapse. This can prevent both perfusion and ventilation problems with that tissue in the lung. You also can have things like hemothorax or a hemopneumothorax. And again, if we break these down based on our medical terminology, we can know that pneumo, prefix pneumo, is air, and the prefix hemo is blood. So where a pneumothorax is air in the lungs, or air filling up the pleural sac within the lung, hemothorax is where blood fills that. Other types of circulatory compromise that can prevent good ventilation and perfusion ratios, things like blood loss and shock. That would be a hypovolemic or low volume shock. We can have things like anemia, where there's a loss of red blood cells. If you remember that red blood cells are the oxygen carrying cells and the carbon dioxide carrying cells within the body. We also can have things like vasodilatory shock. And this is where the vessels, vaso, prefix, dilate. And that's a dilation of the vessels throughout the body that can cause problems with a low volume situation. In managing these patients, it's important that as we assess these patients, we take appropriate steps to ensure our safety as well. Make sure you're wearing the appropriate PPE, and especially wearing things like eye covering and mask for any aerosol generating procedures. And these are procedures in which the patient may expel air and fluid together that can contaminate the provider. So we see things like CPR, where you're pushing on the chest, nebulizer treatments, where a patient is breathing through a tube, continuous positive airway pressure, that's CPAP, positive pressure ventilation, or endotracheal intubations. Anytime that the patient, if you're engaging in airway interventions, it can create some aerosolized mucus or secretions from the patient, you want to make sure that you're taking the appropriate protective equipment, the appropriate protection measures. So when we assess these patients, we need to make sure that we can ensure adequate breathing. Normal adult respiratory rate is between 12 and 20 breaths per minute, and it's a regular pattern of inhalation and exhalation. Breathing should be quiet. In other words, the patient should be making any snoring sounds, sonorous respirations, gurgling sounds. It should be consistent, a consistent rate of inhalation and exhalation, and it should be quiet. If we assess their lung sounds, or we auscultate, and the word auscultate means to listen with the stethoscope, their lung sounds, they should be clear and equal across both sides. That's that word bilateral again. We should have bilateral lung sounds that are equal and clear on both sides. We should see regular equal rise and chest fall bilaterally. And this can be assessed by placing your hands along the lateral sides of the patient's chest wall, and you can feel the chest expand and contract with each ventilation. And they should have an adequate depth or tidal volume. The normal breathing should be regular at a rate between 12 and 20 times a minute. They should have adequate depth, and they should have adequate chest rise and fall, equal bilaterally on both sides. Abnormal breathing is hallmarked by any variation in those. So fewer than 12 breaths per minute would be inadequate breathing. More than 20 breaths per minute could be inadequate breathing. An irregular rhythm, and you can see on the slide here, there's a couple of different irregular rhythms that are more commonly referred to in EMS. You can see that you've got Biot's respiration, and that's a phase, and this is the second one on the right-hand side of the screen. This is a phase of what's called hyperpnea, or rapid breathing, followed by a period of apnea, no breathing, followed by a period of hypopnea, slow breathing. You can see that we also see Kushmal respirations, and this is deep, rapid respirations. And then Cheyne-Stokes respirations, which are irregular respirations with a period of apnea in between. So any of these irregular rhythms could denote insufficient respiration for the patient. Diminished, absent, or noisy auscultated, there's that word auscultated, listened to with a stethoscope, breath sounds, or reduced flow of expired or exhaled air at the nose and mouth. This is common among patients who are suffering asthma attacks. We call them air trappers or COPD patients, where they can't exhale fully, thus creating a large amount of dead space in the lungs and an inability to take in more air. Other factors that can clue us into the patient having abnormal breathing or ventilation: unequal or inadequate chest expansion, an increased work of breathing, shallow depth, if their skin is pale, cyanotic, cool to the touch, or moist, if they're diaphoretic, and that's the word we use in medicine to describe moist skin. Skin pulling in around the ribs or above the clavicles during inspiration. We call this retractions. The patient may also appear to be breathing after their heart has stopped, and this is called agonal gasps. Once again, if their heart isn't beating appropriately, they're not going to have adequate ventilation. It will be important to ventilate these patients. One note about Cheyne-Stokes respirations is they're often seen in patients with strokes, head injury. We can also have things like ataxic respirations. These are irregular or unidentifiable patterns and oftentimes follow significant neurologic insult. Those Kushmal respirations that we talked about, those deep and rapid respirations, these are common in patients with metabolic acidosis because the sensors that we talked about in the body are sensing a lot of acid within the blood. The pH is changed, and they're trying to off-gas carbon dioxide to balance out that pH. Patients with inadequate breathing must be treated immediately. Intervention is required for these patients, and during your assessment phase, and as you're moving through the phases of assessment, if you see a patient without a patent airway or who is not breathing adequately, you must stop and perform an intervention immediately because those are life-threatening emergencies. Clues on the respiration quality of the patient, and if you remember that respiration refers to the exchange of gases, ventilation refers to the movement of air in and out. Even though a patient may be having adequate ventilation, respiration may not be sufficient, thus leading the patient to ultimately become hypoxic. Okay. Clues, these we talked about previously. You can look at clues in the skin, so things like cyanosis, which is what you see here on the screen. The skin becomes blue, particularly in the distal extremities or faraway extremities, fingertips, fingernail beds. And in the mucosa, so looking in the mouth and the lips, they can become blue and pale, and that can be a sign of inadequate oxygenation or perfusion. Ultimately, Inadequate perfusion or inadequate oxygenation and respiration will lead to changes in mental status. Patients will at first become antsy or irritated and then may have completely altered mentation up to and including loss of consciousness. One tool that we use to assess these patients is pulse oximetry. This is measuring, and if you see here on the screen, it shows as a percent of O2. That's 96% SpO2. That's the saturation percentage of oxygen. This tool is measuring the number of hemoglobin in a form of percentage that is saturated with oxygen molecules at the capillary. We look to achieve an SpO2 greater than 94%, but we're not looking to achieve an SpO2 of 100%. An SpO2 should be at 94 or greater with room air, and that's sufficient in most patients for oxygenation. This is a routine vital sign and should be assessed on every patient you encounter. One of the tools we have to assess respiration is measuring the end-tidal CO2. And the end-tidal CO2 measures the concentration of carbon dioxide of exhaled air. This gives us an opportunity to evaluate the final product of metabolism to ensure that perfusion, respiration, ventilation are all working adequately and appropriately. When we're measuring end-tidal CO2, we can do it through capnometry, which is a number. That normal range is between 35 and 45, or we can also measure it with capnography, which prints a graph that you see on the right-hand side. And that graph kind of walks through a little bit with you each phase of exhalation and what that looks like. If we have an end-tidal CO2 that's higher than 45, we would consider that patient to not be ventilating adequately. They're not off-gassing enough CO2. And if they have an end-tidal CO2 of less than 35, we would consider their ventilation too rapid or too fast, both which can be problematic in the respiratory patient.